You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello, and welcome to the In Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. I recently sat down with Mark Mabus, Chief Medical Informatics Officer and Vice President of EHR at Parkview Health. We discussed Mark's healthcare journey, EHR documentation and efficiency with the use of AI, and the challenges of note bloat within patient records. We also discussed a project that improved vaccine reminders in the EHR, which resulted in boosted immunization rates and enhanced provider efficiency. Let's plug in. Welcome to the podcast, Dr. Mark Mabus. How are you today?
I'm all right. Thank you so much for having me here.
It's an honor to have you here. You are a well-established clinical informatician and CMIO and pretty much a very important person. Where do we find you today?
Where do we find me? Well, I am a CMIO in my full title, VP of EHR Clinical and Revenue Cycle Solutions, meaning those things that have to do with our EHR, which is Epic, at Parkview Health. Parkview Health is based in Fort Wayne, Indiana.
So you're a family practice physician.
Correct.
But I think you started off life as a pharmacist. You were born as a pharmacist. Is that true?
If you want to figure out my age, no. So way back in high school, my high school had a mentorship program, and we got to put down what we were interested in, and so they had talked to area leaders in the community, people in Rotary and other stuff like that who would volunteer to be youth mentors, and so I did like a shadowing day of a pharmacist. And thought it was interesting. I always thought healthcare was on the mind, as a potential future career. That or music. I know two totally different things, but that was what was going through my head back then. And after that mentorship, he offered me a job. Actually started work at a pharmacy at 15. Thought that would help support my plans for medicine, no matter if I chose to stay in pharmacy or go on to medical school. And at that time, bachelor's in pharmacy was the degree you got. It was 5 years, got a scholarship for it. So I figured, hey, we'll do this. And so I went through school to be a pharmacist. About my third year of pharmacy school, made that firm decision that I want to go to med school. You need a pre-med degree anyway. So pharmacy was perfect for that. So yeah, I did that. I worked as a pharmacist during med school, even took a full year to work as a pharmacist. So came out of med school with a little bit less debt than my peers, which is always a good thing.
Very good.
Yeah. And then went into family medicine from there.
How many, I don't know a lot of physicians who are pharmacy degrees, who are pharmacists. Like, is there, how many of you exist? Like, have you met dozens, hundreds, thousands?
Handfuls. It was easier when it was the 5-year degree. Now it's a 6-year doctorate program, which is usually a bachelor's 4+2 in the official doctor of pharmacy. So you might get some people that have bachelor's in pharmaceutical science or something along those lines anymore. Okay. But I think it'll be a dying breed. Honestly, my cousin actually did the same thing about 15 years prior to me. And I did meet through our physicians group at Parkview. There was a psychiatrist who actually did the same thing as well. So yeah, there's a handful of us here and there. But like I said, I think it will be a dying breed with the change in the degree program that happened 20 years ago. So
I'm fascinated because I kind of see the evolution of the way physicians work over the last maybe 20 or 30 years from, kind of when I started practicing maybe, which was a gazillion years ago, I want the CT scan that I want and I want it just my way to, I actually had a physician tell me, can't I just consult radiology and have them order whatever the most appropriate study is? Which I was like, that's a very reasonable request. And no, you cannot do that. And I think we're slowly, maybe this is good or bad. I don't really know, but I think we're slowly moving in the same way with some of the sophisticated, complicated pharmaceuticals that we have. Like, hey man, I just want to anticoagulate this very sick patient. And I don't really want to be an expert on anticoagulation. And can't I just, consult someone like a pharmacist to just manage this for me? And the answer is sometimes you can. But it seems like pharmacists are becoming more and more are becoming closer to physicians.
They are for sure. They make decisions about vaccinations, across
Yeah.
the board. That's a big one. I myself still practice clinically 2 half days a week, and there is an embedded ambulatory pharmacist in my office. And let me tell you, that was one of the hardest things to give up when I myself, who am a pharmacist too, said, "Here, you need to dose this warfarin for my patient. Here, help me have this diabetic achieve their A1C goals." I understand because I'm not there all the time. I'm not a full-time clinical person, but just even that core of me, being trained that way too, giving it off to somebody else, it was hard at first. I've got a fabulous pharmacist in my office, so I have no worries there. But it was just that integrating them into the team has been so much more valuable. First starting in the hospitals 20, 30 years ago, when they got more, clinical duties, and now in the ambulatory world too. They know their stuff, and they have been empowered to be able to do that.
Yeah, and it's helpful for all involved if you're able to offload some of the just some of the work, and B, some of the work you're not maybe as good at as others if you don't do it frequently.
And I think some of that background that I have actually transitioned me into that kind of clinical informatics realm too. The whole, I was using software at a pharmacy, filling prescriptions as a teenager, learning that process, knowing the drug background. Fast forward to residency, we were required to become a part of a system-wide committee. So to give us experience, in the administrative side. And so I chose at the time, the pharmacy P&T committee, they let me also do the CPOE committee. So when I was in residency, EHRs were more just for orders, and they were just getting into all the other, bells and whistles that we knew came along with meaningful use at all. But yeah, one of my projects with the CPOE committee was actually helping to design a user interface for drug interaction screens. So this was an old product, doesn't exist anymore. But, what pop-up happened, to a provider that helped them figure out, hey, this is a duplicate drug. This is a drug interaction. Where do we put different alerts on, text on the screen and things like that? It drew from my pharmacy background also, combining it with my medicine background and what I was doing with technology back then. And I think that's what really, solidified my interest in EHRs, and then the optimizations and that whole process going from there. So I kind of fell into that position. When I was in residency, there was no such thing as a, clinical informatics board certification and stuff like that. That came later. I was involved from the start there, transitioned, later in residency, we were making that preparation, this phase to go to electronic notes. And so one of the ways we did that was, create a standard documentation form that had checkboxes and things like that. So it made that transition easier when it happened, because that was a lot of the capabilities of that EHR was the click boxes and stuff like that. So my third year of residency, designed all that form. They delayed our EHR go live, so I never got to do that transition in residency. But it took that information to private practice, thereafter, and use some of those forms again for a couple of years until my private practice went up on their EHR. Then my practice was acquired by Parkview. They saw that, I had done this work previously and integrated me into the system too. They've been live on Epic since 2012, 2013, had me kind of fill in that space in the ambulatory world, starting as a 0.1 FTE, and then it just grew and grew and grew from there.
So you kind of came at it more from the kind of the P&T and the drug interaction checking perspective.
I think that started it all off for sure. And yeah, all the way back to, software that we were using at a retail pharmacy.
So you were not one of those kids programming computers in your basement in junior high?
Not really. I had took a class in basic, one class, didn't use it. In pharmacy school, actually, I did start some HTML programming and started a website that lasted maybe a month or two. It was kind of a blog before blogs were, popular. And I had started writing about, healthcare technology news. So I had a total of like 4 articles in a month's time, and then kind of was like, this is fun, but nobody's reading it. It's kind of, it would have to be a side business venture, and I'm not ready to do something like that. So yeah, I did learn a little basic in HTML, but nothing else. And it really didn't, keep that up too much. It was just, it was using the tools that the software companies were providing. It wasn't programming from scratch.
Yeah, that's fair and probably smart. So how long have you been in your position now as the CMIO?
Oh, so CMIO alone, it's been about 5 years. This past year, I also took on the VP of EHR clinical revenue cycle. That basically means I shifted from, I was in a role that was reporting up through the physician structure at our institution, to a CMO and things like that. I'm now in IS, and I have IS analysts, managers, and directors reporting to me too. So it's kind of a dual role there, because there's the whole IS side, and getting into people management and budgets, which they never teach you in med school. That comes from other education, but still maintaining the desire to have things that CMIOs do, and that's focus on clinician efficiency. Doing both right now, and yeah, that's I think how the CMIO side of things is how things have kind of grown throughout at least the Epic community, for sure, with the presentations that I've done there, and the focuses that I've been able to share with others as well.
Well, let's talk about some of those presentations. One of them was an attempt to, I think, reduce note bloat. So can you talk a little bit about, what do you perceive to be, what is note bloat? Why does it exist? And how do you make it better? I will simply say that when I was a medical student, note bloat meant medical students wrote very long notes on pieces of paper.
Yes, I had that experience too. My very first patient I saw as a medical student, I was given a form to fill out and say, and they were it was in the ER, and they said, here, fill this out with the patient. I'm like, okay. So I did every single line on there, not knowing that, you could pick and choose, what parts of that paper you filled out. So it took me forever, and things like that. But yeah, you're absolutely right. Note bloat was that. Note bloat is basically putting in information into documentation that may not necessarily have to be there, or things that are outside of what a clinician thinks should be in there because somebody else wants it in there. Like, you need to have this in there for billing. You need to have this in here for legal. You need to have this in there to get that prior auth. You need to have this to meet your coding level of specificity so you could get reimbursement for X and X. Notes originally were intended to tell a patient story, and there are all these other things that kept getting added and added in there that the physician ultimately became responsible for doing. And EHRs, kind of supported that, because it was, it's easier. Just put this in there. Just put this in there. And then, there's things that can be automatically put in there. There's things that can be cut and pasted forward. It just became this never-ending cycle of making progress notes bigger and bigger and bigger. The US has the lengthiest documentation of any other country in the world. Things that have been brought to light, ultimately, if a provider's responsible for doing that, which they became that way with EHRs, they didn't offload that to a transcriptionist or things like that. It became more of the provider responsibility. The provider becomes a data entry person, which they never went to school for and don't like doing, but they're required to do so. So note bloat contributes to people not liking their jobs. That's burnout. And how can we, with technology too, can we make this easier? Can we change how the process works? to ultimately reduce burnout. I've called myself a note bloat reduction expert. I'm transitioning that phrase to reducing documentation burden.
Okay.
Basically, there are tools that can make notes look bigger, but more efficient too, like ambient and AI. Those notes tend to be lengthier. But let's get back to note bloat there. So the kind of initiative that I took to kind of start this all off was with some of the changes that CMS clarified in the last 6 years or so. So in 2019, there was this tiny little blurb in the physician fee schedule that basically said, if you've got a certain information in one area of the EHR, you don't have to put it in your actual progress note. It could be linked or reviewed or things like that. That flew under the radar from, I think, so many people until 2021, when the new E&M CPT code requirements came out. These tiny changes were the first changes to, CPT requirements or documentation in general that CMS had done in like 20 plus years.
Sure.
The EHR advent, they were way behind on changing their guidelines to match what EHRs were doing. So the 2019 physician fee schedule change, the 2021 E&M changes for ambulatory, and then for all other areas in 23, those really provided some of the framework that could be used to address reducing that documentation burden. Thanks to friends at Epic, the clinical informaticists there, and the physician well-being services, they were up on this too and starting to promote it throughout the community. Education, had to get the word out. Hey, these changes are happening. You don't have to be stuck in doing what you've been doing for the last X amount of years. You now actually have the opportunity to change that. So first off, what are those changes? Getting that out to providers and our coding and billing staff too. They obviously needed to know that, hey, these are changes. You may see things that are different than how you were taught. Don't yell at providers for doing the right thing by cutting this stuff out of there. So, that education was key.
I want to put an exclamation point on what you just said. I work with healthcare systems all across the country, and I can convince most of the physicians of, don't put this in if you don't think you need it. It's the coders. And it's not always just the coders, but the whole billing apparatus that's been built around the physicians who don't want to acknowledge reality. And I'm stereotyping, of course, but like, there's just so many where they're like, well, that's not our interpretation. And you're like, well, I read English, and
Yeah.
here's the quote, and I'm not sure what's open for interpretation. So is this not a problem for you all in at your health system, or?
It hasn't been because of good engagement early on.
Okay.
Now I'll be completely honest. Before all these guidelines came out, I have that bias too. I don't. And I know this will sound harsh, but I don't want somebody with a 2-year degree telling me what to do, and I think that's the opinion of most physicians in that, they didn't want to listen. And I think it caused, that friction between coding and providers for the longest time. So knowing that these changes were coming, knowing that we would have, the different players in the mix, that was my, olive branch. Reach out to our coding department and explain what's going on, and provide them the information that Epic had kindly collected into documentation that we could share there, to have them discuss with these thought leaders if need be as well. But that engagement from the start, before you actually start making your changes in workflows, I think has been so beneficial.
Brilliant. All right. So you kind of go on a tour, parts of the hospital that many physicians don't see. And then you went to the physicians and said, hey, you don't have to do this. And when they, at least in my experience, when I would say something like this as the CMIO, you don't have to do this, they would always look over to the coder. Like they would lose eye contact with me and look at the coder and see if the coder,
telling the truth?
Yeah. Cause I think a lot of us have been beaten down by the man, it's just been decades and decades of incremental loss of authority, and I was going to say dignity, but maybe that's too going too far.
No, there's a hesitancy to change too. That the trust on the provider side. I know there were quite a few folks that did not go all in when these changes were made. Oh, maybe I'll remove their medication list from my note, but I'll leave that history in there for now. But there's some people that took that type of approach, and hey, I'm just happy that they did something. It's putting steps in the right direction and the thought in the right direction too. The mindset that you don't have to do everything that you were doing there. So part of that whole process in the education was, for providers was to look at what are some best practices that the EHR is providing. So Epic said, use this smart link, not this, because the smart link brings in a big old table and stuff like that. Use collapsing smart link headers and things along those lines. So the informatics team, we were able to take those recommendations, review them, internally, especially with coding and stuff too, and then bring that to the providers and say, hey, here's some options that you can have. Granted, if there were some standard notes that we changed completely, that upended, some of this as well. But, here, individual provider, here are some tools that you can use to change your workflows if you want to. And we kind of left it up to them to iterate how they wanted to. So yeah, it's steps, and it's still going on too. New functionality just last year, we early adopted from Epic, something that they call hover bubble smart links. There are ways that instead of listing out a bunch of information, it's just a line of text, and you use your mouse and hover over it to see your information. We've even got some of those in standard notes that will disappear when you sign the notes. So it's just there for informational purposes while you're, authoring the note, and then gone later. That was a system-wide change that's gone over well. If that information needs to stay in a note, the coding folks still see it. It's been good. So still working on that with ambient, like I mentioned. That does tend to be wordier, how the AI outputs the note in that documentation. But my thoughts on that is that the provider didn't write it. They just have to read and review it quick. And reading is faster than writing. Reading is faster than data entry. So I'm not too worried about character counts going up if somebody uses ambient. I was just worried that documentation burden is lessened. And that we look at other metrics like your time in notes. 8 to 20 minutes on average for our providers who are using ambient. They are spending 8 to 20 minutes less time in notes because of using ambient. So I ain't going to dig them that their documentation is a tad bit longer,
That's fair, but they're not the only ones reading it, right? Their colleagues, you and I, have to read their notes too. So let's talk about ambient. An AI is sitting there listening in the room, making a transcript, one would imagine.
Yes.
And then turning that transcript into a finished note that the physician then reviews. Doing some other things too, at least either now or in the near future, right? Queuing up orders. So when I say, hey, we'll start little Johnny on amoxicillin 250 per 5. And it will automate when I go. I don't have to type that order in. That order will be there.
It'll be queued up for you to, just send along and after review. Yep, for sure.
So that's all brilliant. So there's an arms race going on right now. Who can do that work? One is everyone's going to use one of these two. Or the other option is, hey, there's going to be 20 of these companies. And we should be able to, and I think the big EHR vendors are going to allow us to swap those in and out. Like I can be with company A and I'm like, company B is giving me a slightly better deal this month. Which direction do you think you're going in if we have a prediction? We will not hold you to it, but we will publicly shame you if you're wrong.
I actually wonder if there's more options coming. Like, will the EHRs take this over? I know some of the companies themselves probably are developing some, voice recognition that the development would be so much more accelerated, with this whole GPT and AI world, that I would not be surprised if something happens on the EHR vendor side. Right now, it's all outsourced. I think the big companies are getting big dollars behind them too, especially smaller ones that come from nowhere. And we'll see what their stakeholders say with how things are going too. But this is probably the year of consolidation. There have been so many different vendors out there. I think some of the smaller ones, honestly, are probably going to get eaten up this year or fold because of the prevalence of others. There are EHR companies that do seem like they prefer some vendors over the others, for whatever reasons. That's up to them. I don't want to get into that, but yeah, preferential treatment might also consolidate the field even more. So, I mean, if you're not on some of the big EHRs, there's still plenty of options out there, but they will be dwindling. Honestly, it's going to be down to one or two, or maybe a third will pop up there. Who's got the best deals this month? Absolutely. We have multiple live at Parkview, so you can exist with multiple different, voice recognition vendors at once. The increase in functionality, though, I think with the orders and other things being automatically queued up for providers, I think that's what's going to drive provider engagement. Right now, I still have a lot of holdouts. For whatever reasons, I think, oh, that's nice for the notes. But once it starts becoming that whole integrated experience with orders, follow-ups, and patient education all being brought into one do it for me type things. First off, that's going to be more providers wanting the experience. I think that's going to be absolutely fantastic for not only reducing documentation burden, but reducing burnout, because the computer is doing so much for you. We will finally get away from providers being that data entry person, and they can go back to seeing patients like they went to med school for,
This is crazy talk.
Yeah, I know, but this is kind of that big picture that I see evolving over the next couple of years. But with all that, user interfaces have to change too. The current way we author things in visits and how encounters appear and stuff like that. If we're not doing as much data entry and we're doing data validation, that is going to change what we could have as a possibility in front of a provider on the screen. I might end up just, using it as a reference tool, which is what that computer should be, rather than a data entry tool. So I have big plans that I see, the whole interface changing, whether it's, from, results being shown in one way, the area for documentation being tiny compared to half of the screen like it currently is. I think it's going to open up so many different possibilities for that user experience. I'm excited to see, what we come up with and where that is going once the ambient technology is ready to support that.
It is exciting, and it's all changing so very quickly. I was talking to one of the Epic executives a couple of months ago at a meeting, and I was saying, like, I'm hearing some complaints about one of Epic's AI tools, the in-basket management, I think it's called ART. They were like, well, when are you talking about? Like, and I was like, I don't know, maybe 6 months ago, 8 months ago. And the guy kind of just laughed at me and he goes, oh, that's just talk to me about where we are. I can talk to you about maybe 2 months ago. Meaning that, hey, what it was bad 6 months ago might really have been bad, but it's every month it's changing.
It is changing so fast, for sure. When we first went live on Epic, it was like, oh, here's your yearly update for you. Now it's quarterly. And there's even, the monthly patches that have new things available. You have the opportunity to early adopt other functionality that goes outside of those upgrade cycles. And when do you take that live? But it's always a change there too. Some of it is being driven so fast by the technology changes. Can you keep up with what it's doing? Can you keep educating and iterating? Just even your phone will download a new version of your app every week. And, healthcare's technology is finally catching up to, your app store on your phone. And so it's hard when it affects your daily work that affects someone else's life. But still, it's still a lot of changes, for sure.
Yeah. Well, let's pivot quickly to vaccine reminders. we were just talking about documentation, and I ask not because I'm exceedingly interested in vaccine reminders, although as a pediatrician, I often say I haven't met too many vaccines that I don't love. You made some tweaks to vaccine reminders in your EHR and saw significantly improved uptake. And so love to hear a little bit about that.
Yeah, that was one of my first projects as an Epic physician builder, working with an analyst on that project. We were implementing Epic's health maintenance activity, and which became their care gaps activity. At first, what do you decide to put into health maintenance? There's a lot of recommended content that aligns with national quality initiatives on care gaps, which tend to include immunizations and other things like cancer screenings and stuff like that. So we had implemented a lot of those health maintenance reminders for the standard schedules, the things that the quality measures are built on and things like that. Epic started to release some build for risk-based like immunization tracking, and because they're on a different series than the standard series that's recommended by the CDC. So say that you have a certain health condition, diabetes is an easy one. Guess what? As a diabetic, you're recommended to have a pneumococcal vaccination at a younger age. So things like that, focusing on risk-based, focusing on your individual patient that presents right in front of you. How can you tailor medicine to support their needs, as opposed to a blanket system need or a blanket, quality measure across the system? So it did take a little bit of buy-in, especially from primary care, that will be focusing on these things that are recommended that you should be doing. We're just going to program it into the EHR. So we use some of Epic's standard foundation tools to help with the risk-based series for immunizations. We did have to do some customizations from those foundational rules. The other thing that helped with what we did with our implementation was we also created one-click orders to help providers choose the correct vaccine. So there's the health maintenance framework, and then there's a care gap orders. Care gaps can trigger a order panel for you automatically. You can program in what that needs to be. We took that one step further outside of foundations build and did some custom build that searched for what particular vaccine was recommended, and then match that up to our formulary, what we have in stock at the offices, and basically with one click decide which vaccine to give. We also ended up, later extending that to pediatric combo vaccines, where one click can satisfy all three of those vaccines that are in, like Pentacell, Pediarix, all that stuff. With one click, you got all three, and it satisfied all of those for health maintenance. But yeah, just even not just building it into that health maintenance, which triggers reminders on my chart and stuff like that, but also having the one click, making it so much easier for a provider to just get that order done. So we implemented that and tracked our outcomes over the course of a year. And before the implementation, we had X number. Afterwards, we had 75,000 more. So not only did that provide a revenue increase for primary care, obviously, but obviously public health benefit. We're getting people things that they need that could prevent hospitalizations. And then the individual patient, like I mentioned, these were risk-based. They were tailored to that patient that was right in front of you. What is their risk? Are you evaluating that for that individual person? So that was a kind of newer mindset in how we used the EHR back in 2018, 2019, when that happened, getting my providers to focus on not just their quality metric that affect their bonus. Are you doing the right thing for that patient right in front of you? Giving them the best care.
Sure. I love you're following one of the major things that my co-author and I talk about in our book. Make it easy to do the right thing. And physicians will do the right thing if you make it easy. And so will the patients often, right? And so you followed that and you got success. Well, this has been great. As near the end of our interview, we always like to ask the same question, which is there something that's so well designed in your life that it brings you joy whenever you interact with it? Now, with you, it might be vaccine reminders. It might be that when you're seeing a patient and a vaccine reminder pops up and you got, It's so well designed. I don't know who designed that. Oh, wait, it was me. It was me.
No. I mean, I could go on, and make it the me show and say, it was that song that you wrote, Dr. Mabus, to help promote bending that note curve and reducing documentation burden, or introducing people to that new policy on secure chat, that song that you wrote that was catchy throughout the system. No, because I do that. I've done some wacky things like writing songs and getting words out to providers that way. But you leave this question pretty open ended, in your life in general.
Yes.
And I'm taking it outside of medicine, so you're going to hear a little tidbit about me that you may not have known. I am going to answer this by saying silicone baking mats.
Yes. Bring it.
They are fantastic. Oh my goodness. Especially with kids. I've got 5 kids, and teaching them how to cook on their own, we're recording this just after the holidays. And so there was a lot of cookie making happening at my house, and oh my goodness, those cookies just plop right off. If you've got that baking mat down, we bake a lot of cakes because we got a lot of birthdays, same thing. You got that silicone baking mat in there. They wash off pretty easily. They're cheap. I kind of equivocate to baking. I love to bake myself. It's similar to what I was doing, back in my pharmacy days. We would make drugs, compounding. They teach you how to do that in pharmacy school. It's following a recipe. Guess what? I follow recipes when I cook or bake. I prefer, baking, and my wife does, the savory stuff throughout the week. I bake on the weekends. And so yeah, I'm using some of that stuff myself. So it's so simple, it's so impactful, and obviously food makes people joyous. It's so much fun to share meals with people. So that's another fun part of my lifestyle. I'll throw at you there.
I love it. And it totally meets the criteria of being well designed and bringing you joy.
For sure.
Yeah. Awesome. Well, this was so interesting, so informative. Thank you so much. Are there any YouTube videos of you singing songs that we think might be appropriate?
There are.
Okay.
Oh, for sure. So some of the songs themselves are on SoundCloud. It's soundcloud.com/thedoctor, THEDOCTR. There's no E in there, and it's all one word.
It's like The Weeknd.
Yes. And so that's the best place to just hear songs. I'm on YouTube too as Dr. MK and DOCTR MK. That's got some of the music videos. There's some podcast style interviews that I've done for education up there as well that are for public viewing. Any of that stuff is out there for people to use and see. I've got stuff that is privately available too, because it has copyrighted information in there, so people can reach out to me and ask for some of that content with specific use cases too, and that can also be shared. I love sharing with the community. The communities through informatics. Not just Epic, informatics in general is so supportive of each other. And don't reinvent the wheel. See if somebody's done something. See if there are folks willing to share what they've done, and I'm one of them. So anybody can reach out to me at any time.
Love it. We will throw some of those links in our show notes.
Thanks.
And this would be great. Again, thank you so much for your time. This was so helpful, so informative.
Thank you so much too.
Thanks for tuning in. We hope you enjoyed today's episode. For more on Mark, follow him on LinkedIn at linkedin.com/Mark-Mabus. Check back for more episodes of Designing for Health wherever you listen to podcasts or on NordicGlobal.com. Till next time, we'll see you in network. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.